You're listening to In Good Health, the trusted news source for medicine, science, and technology. I'm Elizabeth Westfield.
I'm Mayan Vasta Betancourt.
And I'm Greg Johnson. This week, male depression may be more difficult to diagnose because we haven't understood their unique symptoms.
They may not be likely to report sadness or anxiety or feeling crying or something like that, but they might be more likely to experience hypersexuality along with substance use.
But first, what's been causing the extreme decline in military suicides?
I've done quite a bit of work in studying trends over time of different kinds of things like this. Honestly, I don't think I've ever seen a reversal or a change that has been so dramatic.
All that and more this week on In Good Health. For decades, the suicide rates of military veterans has steadily increased year over year. When Jeffrey Howard looked into the data for a 2023 paper, he knew how the numbers had been trending, but he wasn't prepared for how dramatic the trends had become.
We had a sense that the veteran cohort would be higher than the total U.S. population and that the TBI group would have the highest. So we kind of expected that. But we didn't really expect the steepness of the increase over time, so that was surprising and kind of alarming to us.
Howard is a professor of public health at the University of Texas at San Antonio.
That's a very steep upward curve. From 2011 to 2020, that decreased a little bit. It went down to about a little over 5.5% per year increase, but still increasing at a pretty rapid pace.
For veterans with a traumatic brain injury, Howard discovered that the average percent increase in the suicide rate was a little more than 7.5% each year between 2006 and 2011. Howard revisited this research for a collaborative study between the Department of Defense and the Department of Veteran Affairs. The 2025 paper in JAMA Network Open has revealed a shocking new trend. Across the board, military suicides have seen a big drop after 2020.
Honestly, I thought it would just kind of be continuing. And so when we saw the reversal, we were actually very excited to see that. I've done quite a bit of work in studying trends over time of different kinds of things like this. And honestly, I don't think I've ever seen a reversal or a change that has been so dramatic. From 2020 to 2022, it decreased by 12% per year for those 2 years. So it's a very strong change in direction with pretty large magnitude. 12% a year, that's over 2 years, that's about 25% roughly decrease.
These numbers are specifically for the veterans with traumatic brain injuries, which means the group with the highest rate has seen the most dramatic drop in suicides.
For the veterans without TBI, the rate of increase per year from 2006 to 2011 was a little under 5% per year, 4.85. And then from 2011 to 2020, it dropped a little bit to 3.41% per year. Still increasing. That's still a pretty large increase per year. And then from 2020 to 2022, the decrease was a little over 7.5% per year.
Though not as large a decrease as the veterans with TBI, Howard says it's still a huge difference seen in just a couple of years. And while this trend is proof that the various initiatives and programs for suicide awareness are working, Howard notes that there's a big issue that needs to be resolved before we can double down on these efforts. We don't know exactly what's been working. It's possible that the cause is a veteran-specific program, because their suicide rates are dropping at the same time that the total U.S. population's numbers are slightly increasing.
There is some evidence out there. There was a study published a couple of years ago in the American Journal of Preventive Medicine that looked at veterans calling into the Veterans Crisis Line. And what it showed was a very big reduction in suicidal ideation for those calls.
The Veterans Crisis Line launched in 2007, but recently became integrated with the National 988 Suicide and Crisis Lifeline. This initiative simplified access to care by allowing veterans to dial 988, then press 1 to speak with a VCL-specific responder. Todd Burnett, the acting executive director for the VA's Office of Suicide Prevention, says this campaign has significantly increased the number of people contacting the crisis line. In 2024, the VCL experienced 39% more calls than the previous year.
It's not more people are suddenly in distress. It's more people are actually connecting to care who've been in distress, but maybe trying to do that alone. When you think about crisis line services, obviously we have crisis responders, men and women who are incredibly talented, incredibly compassionate, and want to help people in the time of need. Our average response time, so we had 1.2 million calls last year, and we still answered that line within 8 seconds. When you think of the national standard for that's 20 to 30 seconds, we're still answering that within 8 seconds, and your average encounter with them is about 40 minutes long. And these people then get connected to whatever resources they need to help save a life.
And again, the crisis line is just one of many solutions put forth to reduce veteran suicides. While this program has proven to be life-saving, a main pillar of the VA's mission is to provide resources and support before someone is ever in a crisis situation. They've been using an effort called Risk ID to help identify veterans who may be at a higher risk of attempting suicide.
There are characteristics or traits that you can look at that help anticipate or project risk for suicide. And when you look at someone's entire medical record and you put all these factors together, you can actually predict people who are going to be at highest risk for that, and then proactively work to engage them.
Burnett says they'll reach out to see what struggles these veterans are having and figure out what type of support is needed. These services go far beyond mental health support and suicide prevention programs because there are many other drivers of suicide that stem from issues like homelessness and insomnia.
Other common drivers for suicide risk are things like pain, which is common in the U.S. population, and about 20%, 24% of the U.S. population struggles with pain. But when you talk about veterans, that rate is almost twice as high, that they struggle with chronic pain or things like insomnia or traumatic brain injuries or those sorts of things. And so we can identify people who are at risk, who may have not only those things, but other factors that present some challenges for them that may elevate their risk, and get close to them. Help push resources to them, email or text them with, hey, did you know, kind of resources for their caregivers or family members, and resources for community members that might be around those veterans to help connect. So we're not just going at the veteran, we go to their support networks and the communities around them to try and kind of make those resources and conversations as open and as accessible as possible.
Creating connections is another main pillar of the VA's suicide prevention. Burnett says that over the last 2 decades, a majority of veterans who took their own lives did not have any contact with VA resources.
It's been around 60% of veterans who die by suicide have not had any contact with VA for any services whatsoever, either in the year of or year prior to their death by suicide. That rate has gone as high as 73% back a few years ago. Congress has done some wonderful things to help address that, and by opening up, making it much easier to get connected to VHA care. And so you've seen some of the fruit of that, which has lowered it from 73% down to 60, but that's still way too high. That 60 to 73% of veterans who die by suicide, I never had the opportunity to help because they didn't come for help. That's where we need to make a change, and that's where I need everyone's help in doing that.
Burnett is a firm believer that the suicide crisis requires all hands on deck, which is why the VA has partnered with various medical, religious, and social programs across the nation.
You see us doing a lot with partnering with faith-based organizations, as well as vet centers and other community organizations that are often the first places that a veteran in distress may go for supports, because we want to help them be equipped so that when that veteran comes to them, there's no wrong door, that veteran can get connected from wherever they go to whatever they need. If a veteran doesn't want to come to us, that's okay. We want to help connect them to whatever resources they need from whomever they want to receive it. So you see us doing a lot of education and resource pushes to community providers who might come into contact with veterans, so that if that veteran wants to get connected with them, those providers know how to help get those veterans the benefits they deserve and those supports that they need. And so we're doing both an outreach directly to veterans, as well as a lot of push to their support networks to make sure they feel equipped.
One service working towards this goal is the Staff Sergeant Parker Gordon Fox Suicide Prevention Grants Program. It provides resources to community organizations that are filling in the gaps where the VA can't yet reach.
And these are grants that we give to community organizations, often in areas where veterans are challenged to be able to get to services. Either they don't have a VA option close to them, or they just don't have many options, period. Or they do, but they don't feel comfortable connecting to them. And so we have these collaborations with local community-based organizations to help provide connections not only to veterans and service members, but to their families. So if a veteran's family member who's struggling comes in, that impacts the veteran. And so the better that family does, the better the veteran does.
Burnett estimates that this service will double in size in 2026 due to Congress allocating more funds to expand the program. So whether it's direct contact or community-based outreach, the VA has numerous initiatives working towards ending veteran suicide.
The message there is we have help for whatever you're challenged with. Either we can help you with it directly through VA, or we can help connect you to a community partner. We can connect you to whatever those answers are. Suicide is not an inevitable outcome. Sometimes people, when they face things that are challenging, whether it's a traumatic brain injury or a trauma, or they're struggling with substance use issues, or they've lost a job, or their marriage or something is struggling, you can feel overwhelmed, you can feel hopeless, but there's a way to navigate forward.
So while we don't yet know which specific programs are having the most impact on the recent downward trend, both Burnett and Howard believe we need to keep up the current efforts until researchers are able to pinpoint which initiatives to pour more resources into. Visit va.gov/reach for more resources. You can find more information about Todd Burnett, Jeffrey Howard, and all of our guests on our website, ingoodhealthpodcast.org. For more behind the scenes, follow In Good Health Pod on Facebook, Instagram, and X. Our writer-producer is Kristen Farrah. Our executive producer is Amira Zavari. I'm Elizabeth Westfield.
Coming up, why we need more awareness around the mental health of new fathers when In Good Health returns. Around 1 in 8 women experience postpartum depression, and thankfully there are numerous resources across the nation these moms can lean on during such a stressful time. As mental health has become a more common conversation, awareness around PPD has grown as well. But what's lacking from this discourse is the fact that men are also having these experiences, which have been labeled paternal postpartum depression.
About 1 in 10 fathers deal with postpartum depression, and there's a heightened risk around the 3 to 6 months postpartum when they are getting more involved with the child, that they start to feel that stress and heightened risk for developing depression. But of course, we also understand that this extends even beyond the first year postpartum, up to about 5 years when the father is at risk for developing depression.
That's Dr. Sheehan Fisher, Associate Professor of Psychiatry and Behavioral Sciences at Northwestern University Feinberg School of Medicine. His research focuses on fathers' maternal health. Fisher says the 3 to 6 month window of increased risk stems from dads being more involved with their children, but this rise in risk doesn't mean their involvement is a bad thing.
We want them to be involved, but just like with the moms, that if they deal with more stress, therefore they put them at risk for depression, specifically and especially if you have a history of depression or other mood disorders or have a vulnerability to those things. So it's just kind of the combination between your own body and the environment that could put you at risk for developing depression.
Fisher says paternal PPD partially comes from men in today's world taking a much more active role in parenting without a lot of education or knowledge being passed down to them.
I think for men, especially current men, they, for the first time, are becoming the involved father. Many times their fathers were not involved as much, and therefore they want to be involved themselves without really a blueprint on how to do that. And we also don't have really the system support to help them. Like we don't have as much parenting education for them. We don't allow parental leave as much for fathers. So therefore they get either shortened leave, like 2 weeks, or nothing at all, which makes it harder for them to transition to this new role and for them to be fully involved as a co-parent. And so therefore, these policies really kind of limit this transition, and it creates more stress upon the father.
Thankfully, there are programs available that focus on paternal PPD, such as Postpartum Support International. They have resources for both men and women that include support groups and mentor programs.
But I think there's a lot more we need to go to really have it more accessible. Like for one, perinatal mental health specialists need to get trained in father mental health, because many times they're only trained it on the mom side. So I and other colleagues, especially through Postpartum Support International, have done trainings to different clinics and organizations and clinicians to make sure they're informed. One of my things I always push out is that I don't need everyone to be a father specialist, but I need to at least understand how the father relates to their work. So even if you're an OB-GYN or pediatrician, which the father is not your target patient, you still need to at least understand how the father's mental health affects your target patient, and also how you can incorporate the father to the overall well-being of the family.
This full picture approach is crucial for the family's health. Fisher says that research shows a high correlation between one parent's mental health struggles increasing the second parent's risk as well.
If one person is depressed, there's a high risk that the other person will develop depression, and for either parent. So this is something we also want to take into account, that if you see, let's say the OB-GYN that sees a mom, if she's depressed, you should be looking out for, is their partner also depressed?
And obviously, the mental health of both parents has an incredible impact on their child. There's a long history of research showing the immense influence a mother's mental well-being has on the kid, but Fisher's research has revealed just how powerful the father's mental health is too.
The father's perinatal mental health has a direct impact on that child's internalizing, which is like the anxiety or sadness and depression symptoms, and externalizing the behaviors, which is like the misbehavior or aggression, similar to mom. So therefore, clinically, this matters, because if we only treat the mom and support her mental health and well-being and get her well, we are still leaving that child at risk.
But if most parents want to do what's best for their child, why are so many fathers ignoring their mental health? Fisher says it's simply been lumped in with the general trend of men not taking care of their overall health.
Like we're talking about even physical health in general, men many times don't go to their PCP or their primary care physician, or even take care of their symptoms until it gets like exacerbated. But then when we think about mental health, all the more so, men are less likely to go see a psychologist or a therapist or a psychiatrist to support their mental health well-being. And this is all the more so during the perinatal period, because fathers feel the pressure to want to be strong for their partner, for their family, and don't feel that they really have a space for them, that they aren't supposed to feel anything. So therefore, if they're feeling something, must be something wrong with them as an individual.
They're also feeling these intense emotions during a time that's already a high-pressure, novel experience. For many men and women, it's easy to chalk up any weird feelings as part of the journey. Fisher says it's normal for parents to not even really be aware that their mental health has taken such a hit.
So often, especially if the mom is dealing with depression or other mental health issues, or even medical issues, given like a high risk after delivery, they're so hyper-focused on making sure she's okay, they are in like go mode. They're not really aware of what they're going through themselves. And therefore, sometimes it's not till much later they start to realize that they're not themselves and that they don't feel well, but don't always even have the language to explain what they're going through.
It's possible that they don't have the language, because even scientists didn't really have a good grasp of male depression until relatively recently. Fisher says many men experience depression differently than the symptoms we typically think of. This subtype has been deemed masculine depression,
which means they may not be likely to report sadness or anxiety or feeling crying or something like that, but they might be more likely to experience hypersexuality, hyperaggression, including irritability, along with substance use.
Which means there's a possibility that many men with depression have been misdiagnosed because the medical professionals were analyzing the wrong symptoms. In fact, this recent data has led researchers to believe that the difference in depression rates between men and women hasn't been accurate.
There's a study done by JAMA Psychiatry on men in general, and basically we've always known the ratio for depression is about 2 to 1 for women to men. But what they did is they added in masculine depression symptoms, and that ratio went from 2 to 1 to 1 in 1. Which meant basically they're at the same risk for depression in general for men and women. I am concerned we're looking at the same problem when it comes to perinatal depression, that we're underestimating how many fathers are dealing with depression during the perinatal period, which means that we then don't know how to best support that family if we're underestimating their risk of depression.
Fisher says the scientific community has been slowly integrating the masculine depression symptom scale into research, but it's not widely used just yet.
People are starting to now consider it within their clinical settings and within their research to include these additional measures. But I don't feel like we've gotten fully there to be able to then do a meta-analysis on understanding that within the perinatal field. But we do need to move in that direction. So I think we are making progress on the medical field to understand it, even though we still have a lot of, misinformation or bias against like some of the views around father mental health and trying to understand how it incorporates, but we're making progress.
The next step for Fisher is to make this topic more well-known in society.
Even as a researcher and a clinician, a lot of what I've done in my career now more recently is moving toward media and other outlets to make sure that we inform others in general about like how their mental health is impacted by going to parenthood, whether mother or father, but also seeing the relation between the two. So I think we do have to make sure that the public is more aware that this exists so they can prepare and be ready to be able to support each other as they go through this life transition.
You can find more information about Dr. Sheehan Fisher and all of our guests on our website, ingoodhealthpodcast.org. For more behind the scenes, follow In Good Health on Facebook, Instagram, and X. Our writer-producer is Kristen Farrah. Our production manager is Jason Dickey. I'm Greg Johnson.
In Good Health returns in just a moment.
Medical notes this week. Your choice of cooking oil might be doing more than just seasoning your food. A study published in the Journal of Lipid Research suggests that soybean oil, the most widely consumed oil in the United States, is linked to significant increases in obesity and diabetes. Diets high in this oil led to unique changes in gene expression within the liver. These genetic alterations can disrupt the body's ability to regulate energy and metabolism, potentially fueling the current obesity epidemic. A breakthrough in mental health treatment is offering new hope for those living with schizophrenia. A study published in Nature Mental Health highlights the first new class of schizophrenia medication to be approved in over 50 years. Unlike traditional antipsychotics that block dopamine receptors, this new drug targets receptors that balance certain signals in the brain. Clinical trials showed a significant reduction in symptoms like hallucinations and social withdrawal for some patients, though not all participants responded as well. The hidden timers in your brain may hold the keys to your memory. According to research published in Nature, scientists have identified specific neural patterns that track the passage of time during the formation of memories. This allows the brain to timestamp experiences and sorts which ones go into our long-term memory. Understanding these markers could be vital for treating conditions like Alzheimer's, where the chronological order of memories is often the first thing to fade. And finally, checking in on your employees' mental health might require more than just a yearly survey. A new research report by Johns Hopkins reveals that well-being fluctuates significantly throughout the work week, suggesting that one-and-done annual reviews provide an inaccurate snapshot of organizational health. The team recommends a more dynamic approach to monitoring morale, allowing companies to implement real-time support systems that prevent burnout before it starts. And that's Medical Notes this week. I'm Mayan Vasta Betancourt.
Thank you for joining us this week and every week as we break down the science stories you need to know. You can find all of our past segments and guests on our website at ingoodhealthpodcast.org or wherever you listen to your podcasts. Follow us on Instagram, Facebook, and X for more behind-the-scenes content. Tune in next week for another edition of In Good Health.